Dr. Montserrat de la Torre and Dr. Ana María Colino. We are both residents of surgical pathology at Hospital Clínico San Carlos in Madrid, Spain. First of all, we'd like to thank the organization for inviting us to contribute in this 47th World Seminar on Women's Health and Nurturing. We have recently made a study of the impact of human papillomavirus vaccine on the development of cervical lesions in our hospital, and we would like to share it with you. Human papillomaviruses, HPV, are members of Papillomaviridae family, with over 2,000 subtypes identified. These epileptotropic viruses contain double-stranded DNA genomes of approximately 8 kV, encapsulated within non-enveloped particles measuring 52 to 55 nanometers in diameter. HPV is the most prevalent sexually transmitted infection worldwide, causing both benign and malignant lesions in men and women. All serotypes known up to now have been classified into 3 risk groups: high, low, and indeterminate, based on their association with malignant transformation of cells. Therefore, the associated risk of these benign or malignant conditions varies depending on the HPV serotype. The high prevalence of human papillomavirus infection and its relationship with disease underscores its relevance for public health. The main risk factors associated with the development of cervical cancer include high-risk human papillomavirus infection, age, smoking, childbirth, multiparity, oral contraceptive use, diet, and immunosuppressive states, particularly due to HIV. Among these various risk factors, persistent infection with high-risk HPV appears to be the primary driver of cervical carcinoma development, arising from normal cervical epithelium through a progressive development of low and high-grade cervical intraepithelial neoplasia. However, the severity of the outcome toward cervical cancer development depends on specific HPV subtypes. The genome of all HPV contains 3 functional parts: the early region, E, which encodes protein E1 to E7, necessary for viral replication; the late region, L, which encodes structural proteins L1 and L2, required for viral assembly; and a mostly non-coding part called the long control region, which contains the element necessary for viral DNA replication and transcription. HPV infection occurs when viral particles reach exposed basal cells, usually through mycotrauma in the epithelium. Sites where the infection appears to be facilitated include the transitional epithelium of the cervix and anal region, specialized epithelium of salivary glands in the oral cavity, tonsillar crypts in the oropharynx, hair follicles, eccrine and apocrine glands, as well as the epidermis. Most viruses clear up within 2 years, but some persist, for example HPV 16 and 18. Protein E5 contributes to evasion of immune system. Expression of viral oncogenes occurs in basal layer. For this to occur, transcriptional activators like E1 and E2 are necessary for viral replication. Protein E5 alleviates cellular dependency on growth factors, and this will end in cell proliferation. Protein E6 binds to p53 and causes degradation, as well as protein E7, which will bind to Rb and cause as well its degradation. All of these will end into somatic mutations and integration of HPV into host genome. Dissemination through supravial layer will need binding of L1 protein to basal membrane heparin sulfate. After 2-4 hours, it will occur the internalization of the capsid. Protein L2 contributes to viral genome entry into the nucleus. As the virus reaches the upper layers of epidermis or mucosa, complete viral particles assemble and are released. Progression for high-grade lesions to carcinoma requires the accumulation of additional epigenetic and genetic alterations, a process that can take 20 to 30 years. Hypermethylation of CpG islands in the promoter regions of tumor suppressor genes has been recognized as a molecular change from HSIL to cervical cancer. Considering the etiopathogenesis and natural history of cervical cancer and its precursor lesions, particularly after the recognition of HPV as a causal agent, there is clear evidence of the prognostic advantage of early diagnosis through the implementation of screening protocols. In Spain, a screening protocol has been followed since 1918, with the primary objective of early detection and treatment of lesions caused by persistent HPV infection. However, it wasn't until 2018 that the World Health Organization declared cervical cancer as the first eradicable cancer, calling for global implementation of screening and vaccination programs. Implementation of this program has reduced incidence and mortality of this infection by 70 to 80%. During the early years of sexual activity, the incidence rate of HPV is higher compared to other age intervals. However, most of these infections are transient and do not persist in women. It is after the age of 30 years that, although the incidence of infection decreases, the infection tends to be more persistent, increasing the risk of developing precursor lesions of cancer. Taking this into consideration, the World Health Organization, European guidelines, and scientific recommendations approved in 2018 states that the target population of this protocol should be women between 25 and 65 years of age. Accordingly, women between 25 and 30 years of age should undergo vaginal cytology every 3 years. In general terms, there are two types of screening protocols. On one hand, there is opportunistic screening, where the patient requests screening during a medical consultation for another reason. This is a non-systemic process, which raises questions about its effectiveness and efficiency. This type of screening hampers optimal coverage and penalizes equity, and it focuses more on women with low risk rather than those with high risk. This situation is in line with different socioeconomic and cultural situations in society, representing a significant limitation of the screening protocol. That is why, in Spain, the 60% of cervical carcinoma occurs in women who have either undergone inadequate screening or have been exempted from it. In contrast, population-based screening offers a systematic and active screening to a target population within the healthcare system, allowing continuous evaluation of quality and outcomes. Among the main benefits of this screening protocol, the following can be highlighted: a higher cure rate after early diagnosis, improved quality of life for the patient after treatment, and the assurance that a woman is not carrier of precursor lesions or cervical cancer in case of negative results. However, the greatest achievement is the increased detection capacity for thin 3 lesions and the greater reduction of thin 3 is interval before the next screening test. As for the harms, noteworthy issues include the risk of overdiagnosis without a benefit in terms of cure, the overdiagnosis of low-grade lesions and that will not progress, subjecting the patient to unnecessary treatments and anxiety, and the impact mobility and fertility due to falsely positive results, as well as a false recurrence and delayed diagnosis in case of a false negative results. The distribution of human papillomavirus prior to the implementation of the vaccine has been extensively studied. According to the studies conducted by G. Bologna in the year 2000, the prevalence of high-risk HPV was 73.5% in HL, 98% in squamous carcinoma, and 100% in cases of adenocarcinoma. HPV-16 was the most represented type in all lesions, with a 71.2% of HCL cases, 73.3% in squamous carcinoma, and 50.6% in adenocarcinoma. Focusing on the period following the implementation of the vaccination schedule, slight changes have been reported compared to previous data. In 2012, Penguin et al. Conducted a meta-analysis on the cross-sectional distribution of HPV types in 150,789 HPV-positive women. No significant difference were observed in the distribution of HPV types among normal cytology, ASCUS, L0, or SIN1. However, HPV-16 positivity increased abruptly from normal or low-grade lesions to high-grade lesions or carcinoma.
Dr. Montserrat vaginal descriptive study based on the results of the usual clinical practice and performed at Hospital Clínico San Carlos of Madrid in Spain. Our hospital provides health coverage to different districts of the capital, covering a population of over 400 people, which represent 12% of the total inhabitants of Madrid, among which there are different nationalities of various continents. The most prevalent of them, and therefore in our sample, are nationalities from Latin countries, followed by North Africa, Eastern Europe, and China. Analyze the change in the type of lesions developed by HPV-infected patients after the introduction of the vaccine in the Spanish health system, covering a total period that will go from 2002 to 2021. The samples included women from Hospital Clínico San Carlos and the dependent health centers that underwent cervical biopsy with lesion caused by HPV and that showed positivity for it with the genomic kit for HPV detection. Patients with HPV-associated lesion in other locations, anus, vagina, vulva, and oropharyngeal regions, men, as well as other types of lesions present in the cervix that were not related to HPV, are excluded. For the purpose of this study, lesions in uterine cervix caused by HPV infection have been reviewed in 3 time periods encompassing years prior to the introduction of the vaccine in 2002 to 2006, years when the vaccine had been implemented for a short time, to 2009 to 2011, and more recent years where the vaccine has been administered for more than 10 years, and therefore more women should be covered by it, 2020 and 2021. We have compared the main types of virus involved in high-risk lesion in the periods 2002 to 2006 versus 2020 to 2021, and finally we have compared the mean ages of high-risk HPV-associated lesions in the different periods time.
The number of biopsies with HPV-related lesions in the different periods of time studied were 116 biopsies for the first period, 386 biopsies for the second one, and finally 462 biopsies for the most recent period, 2020 to 2021. Consequently, we have analyzed a total of 946 women affected with HPV lesions. Regarding low-risk lesions, SIN1, an incidence range that reaches 61% in the first years, 44% in the years 2009 to 2011, and 38% in the years 20 to 2020 is verified. Considering high-risk lesions, THIN2 and THIN3, its incidence reaches a maximum value of 29% in the first interval, 48% in the second, and finally 59% in the last period of time. On the other hand, the incidence of patients diagnosed with squamous cell carcinoma reaches a maximum value of 44% in the years 2002 to 2006, 26% in the years 2009 to 2011, and 5% in the most recent years 2020 and 2021. It is worth noting the absence of records in our series in the years 2002 to 2006 of adenocarcinoma and its diagnosis in the years 2009 to 2011, reaching the 0.99%, when in the year 2020 and 2021 it reaches a maximum of 2%. T-squared tests confirm a statistically significant difference in the rate of different high-grade lesions caused by HPV infection between the 3 periods of time. The evolutionary trend of each type of lesion has been analyzed in the different time periods of our study, showing a stable trend for SIN1 and adenocarcinoma, an upward trend of high-risk SIN2 and C3 lesions, and a decrease in the rate of squamous cell carcinoma. On the other hand, the different serotypes that caused lesions in our patients between the first study period prior to the vaccine, 2002 to 2006, and the most current period after its introduction, 2020 and 2021, has been analyzed, the results of which are shown in Figure 5 and Figure 6. We make a distinction between usual high-risk serotypes 16 and 18, which in the first time interval caused the 47% of the lesions compared to the 44% in the last period analyzed, and other high-risk serotype less frequent, whose incidence varied from 20% in 2002 to 2006 to 40% in the 2020 and 2021. The undetermined risk category originated the 14% of the lesions in 2002 to 2006 and reached the 28% in 2020 and 2021, while the low-risk serotype were responsible of 17% of the lesions in the first time interval and 6% in the last one. The mean ages of patients at the time of diagnosis of high-grade lesions and cervical carcinoma were studied, results of which are shown in figures 7 to 9. It should be noted that in the first years studied, the mean age of diagnosis of SIN2 and C3 was 30 to 43 years. In 2009 to 2011, it was 34 to 37 years, while in the year 2020 and 2021, the mean age was between 37 and 39 years. Squamous cell carcinoma was diagnosed between the ages of 27 to 38 in 2002 to 2006, remaining at approximately 50 years of age between 2009 and 2011, and fluctuating between 50 to 54 years of age in 2020 and 2021. Finally, no record of any adenocarcinoma was obtained in the first time interval. However, in 2010, those diagnosed correspond to patients with a mean age of 56 years. In 2020 and 2021, the mean age was also of 56 years.
Now, I will proceed to justify the results we obtained, discuss high-grade lesions unrelated to HPV, and comment on the strengths and limitations of our study. With regard to the analysis of the data we have obtained, this slide summarizes the results that my colleagues discussed earlier. In our study, there's a recent upward trend in uterine cervix carcinoma precursor lesions, SIN2 and 3, contrary to the expected vaccine negative trend. It's crucial to consider socio-demographic factors influencing HPV infection. In recent years in Spain, changes in sexual behavior, including earlier sexual activity and increased partners, are notable. Lack of information among men, absence of a male HPV vaccination program, and immigration from countries with inadequate screening contribute to the trend. On the flip side, high-risk lesions in fully vaccinated individuals may result from pre-vaccination infection or infections by other prevalent high-risk serotypes. This study shows a 50% decrease in infectivity rate for well-studied high-risk serotypes protected by vaccine and a 50% increase for other high-risk serotypes. This highlights vaccine efficacy and emphasizes the need for a strategy covering newly prevalent serotypes. Additionally, further studies are required to categorize serotypes with indeterminate risk. Regarding low-risk serotypes in SIN2 and 3 lesions, we believe they result from co-infection, as no exclusive case caused by low-risk serotypes were observed. Their decreased infective rate may be due to vaccine protection. For squamous cell carcinoma, we have observed a decline in incidence and a decrease in the average age of diagnosis over recent years. Increased population screening allows early detection of precursor lesions, justifying the incidence decrease. However, the average age of diagnosis in our area has risen from 29.5 years in 2002 to 54 years in 2021. This increase can be attributed to factors such as women not entering vaccination programs, not receiving vaccination, lacking proper screening, or being of foreign nationalities. As for adenocarcinoma, the present research detects an incidence clearly lower than squamous cell carcinoma in all the years of study. However, it is necessary to consider that the pathogenesis of this type of neoplastic lesions is less related to HPV infection and may even be independent of it. Additionally, the most well-known serotypes implicated in its etiology are 16 and 18 serotypes that, once again, are better covered by the vaccine. Regarding to the average age of diagnosis for these lesions, a stable trend around 56 years old has been observed in the analyzed time periods. It is important to note the smaller number of patients with this type of lesions in our sample, with no cases recorded in the 2002 to 2006 interval. So this data may not be entirely representative of the rest of the population. Another important point to consider is that we must highlight those patients in our series who had developed HPV-related lesions but tested negative for the implicated serotypes during molecular analysis at the time of diagnosis. In this regard, there are different hypotheses proposed in various studies. It has been highlighted in the literature that between 5 and 30% of patients with cervical lesions have a negative molecular HPV test result. In our sample was about 7.61%. Some of the cases we consider include false and true negatives, as well as the role played by the microenvironment and immune factors in vaginal and cervical secretion. Several authors have suggested that these false negatives could be infection caused by virus genotype not currently included in a standard testing platform, as well as variability in sampling, low viral load, decreased transcriptional activity, technical errors, or rapidly progressive cancer that develop between cervical cancer screening intervals. A novel approach that could improve screening is to use viral load as a biomarker for triage, as there is a significant correlation between increased viral load and the severity of cervical lesions. However, further research is needed to determine optimal cutoff points and evaluate the feasibility and effectiveness of this strategy in different population and clinical settings. In very few cases, squamous cell carcinoma in the cervix has been reported with truly negative high-risk HPV detection. In 2022, Rogor et al. Presented the first histological description of high-grade cervical lesions negative for HPV that were not associated with invasive squamous cell carcinoma. Initially, HPV negativity was defined as the absence of DNA from 32 HPV serotypes, absence of mRNA from E6 and E7 of 14 HPV serotypes, and the absence of HPV sequences in wide genome sequencing region. It was found that all these lesions occurred within the metaplastic squamous epithelium of the transformation zone, with an abrupt transition between the precursor lesion and the squamous epithelium of exocervix. The majority resembled HPV-induced high-grade squamous intraepithelial lesions according to the Hugh definition, and undifferentiated basaloid proliferations, but some precursor lesions were highly keratinized proliferation similar to differentiated vulvar and intraepithelial neoplasia, shown on diffuse P16 staining. In cases of keratinized invasive squamous cell carcinoma of the cervix negative for HPV infection, a sprightly vascularized stroma was observed, along with a dense inflammatory infiltrate that included numerous stromal and intratumoral eosinophils. All these cases had clearly identifiable intraepithelial precursor lesions and lacked P16 staining. On the other hand, Hanahan and Weinberg have proposed that the microenvironment and immune factors in vaginal and cervical secretions play a crucial role in the development of lesions in patients with negative high-risk HPV. Cervical neoplasms are complex biological behaviors, and their development is actually a process in which tumor cells interact with the body environment. The cervical immune microenvironment includes vaginal microecology and the local vaginal immune system. Vaginal microecology, with its main components being Lactobacillus vaginalis and the microbial flora, under normal circumstances maintains a dynamic balance. But when this balance is disrupted, the number of lactobacilli decreases or their function is inhibited. The acid vaginal environment is destroyed, hypoxia occurs, local immune function is reduced, the antitumor effect weakens, and cervical lesions are prone to occur. The local vaginal immune system, which includes AL2 and AL10 representing cellular immunity, Th1 and Th2 cells that can enhance cellular immunity and suppress immune response, respectively, and secretory immunoglobulin A and immunoglobulin G, which are the main components of humoral immunity. It has been observed that the expression of AL2 is decreased in cervical cancer and precancerous lesions. There is an increase in the level of AL10 and a decrease in secretory immunoglobulin N and immunoglobulin G in vaginal infection. As the lesion progresses, AL2 decrease, AL10 increase, the Th1-Th2 ratio decrease, Th1 shift to Th2, immunosuppression occurs, and cervical lesions develop. However, due to the small number of precancerous lesions and HPV-negative invasive squamous cell carcinoma, many questions remain unanswered regarding their cellular pathogenesis, as well as the triggers and drivers of this abnormal proliferation and the natural history of HPV-negative squamous cell carcinoma. Considering the potential role of the vaginal microenvironment, there is need to work collaboratively as well as the need to implement therapeutic measures that promote a healthy vaginal microenvironment in patients infected or with HPV-induced lesions. Regarding limitations, in the earlier analyzed years, patient numbers were considerably lower due to the lack of hospital computerization from 2002 to 2006, gradual implementation in subsequent years, and incomplete medical record transfers to the hospital intranet. Additionally, during the same years, we lacked HPV test results for cases conducted in other facilities due to a lack of interconnectivity. Moreover, the study includes data from 2020 and 2021 amidst the global COVID-19 pandemic. This may have led to a decrease in registered cases, particularly in 2020, and a delay in diagnosis and patient follow-up. However, since the study is conducted in 2023, it is considered that not enough time has passed for underdiagnosed or poorly followed-up patients in 2020 to have developed high-grade lesions or squamous cell carcinoma. Surgical interventions for patients with SIN2 and 3 lesions diagnosed before 2020 but after 2011 may have been delayed, but this wouldn't affect the study results. As strengths, we will highlight the large sample size and extended study period, which have allowed us to draw statistically significant conclusions that support the effectiveness of current vaccine against different serotypes of human papillomavirus. Our study affirms the vaccine efficacy against specific HPV serotypes, evidenced by a decline in the incidence of cervical squamous cell carcinoma in our population. This decline is accompanied by an increase in the average age of diagnosis and a shift in the infective trend towards not covered high-risk HPV serotypes. Recognizing the impact of HPV infections on both men and women's health with its carcinogenic risk emphasized the necessity for further studies. These studies should accurately categorize serotypes which are no risk and promote new vaccine development for currently prevalent serotypes. Additionally, the increased incidence of premalignant lesions since 2 and 3 can be attributed to enhanced population screening criteria, improved diagnostic techniques such as liquid cytology, and heightened awareness about HPV infection. This increased awareness leads to greater participation in population screening, enabling the detection of lesions before reaching carcinoma stages. Well, and finally, this is the references that we use to make this little talk.
Dr. Montserrat.
And finally, thank you for letting us to participate with this talk.